Welcome back to the Endo and Fertility Space channel. In today's video, I had the pleasure of interviewing Dr. Francesco. Dr. Francesco is a highly accomplished consultant thoracic surgeon with extensive expertise in advanced minimally invasive surgery. He has been a substantive consultant since 2016, practicing at the John Radcliffe Hospital, Oxford, where he specializes in the treatment of thoracic endometriosis, thoracic outlet syndrome, rib fractures, lung cancer, and catamenial pneumothorax, as well as performing complex diaphragmatic procedures. Renowned for his pioneering contributions, Dr. Francesco introduced Uniportal VATS at multiple institutions, including Oxford University hospitals, where he also lectures on anatomy to medical students. He has performed complex procedures using this innovative single-incision technique and serves as a proctor for advanced minimally invasive thoracic surgery, sharing his expertise with peers internationally. In today's interview, I spoke with Dr. Francesco and we discussed signs and symptoms to look out for that might indicate thoracic endometriosis. We also discussed the steps you, the patient, can take to get a faster diagnosis and what medical testing to request specifically if you suspect you may have thoracic endometriosis. We also spoke about new and exciting research happening in the thoracic endometriosis space. I hope you enjoyed this interview as much as I did. Happy watching. Okay, we're recording now. Excellent. I am so grateful for your time, Dr. Francesco. You are a popular guy, very much in demand, but your area of expertise is something I've wanted to find somebody to chat to. I was so happy that I came across Dr. Martin Hirsch's live with you. And I was like, oh my goodness, as soon as I watched that, I was like, I need to ask Dr. Francesco if he will chat with me. So to start us off, my first question to you is if you could just give us a brief intro of who you are and what makes you a great person to talk to about thoracic endometriosis.
Thank you. I'm Francesco. I'm a consultant thoracic surgeon. I work in Oxford, in the United Kingdom, and I have a long-standing interest in catamenial conditions, including pneumothorax, and also vast experience in the surgery of the diaphragm. And the combination of these two has led me quite naturally to be involved with thoracic endometriosis. It's quite a long-standing interest, and I am now with Martin and with Andrea and many other excellent gynecologists like Marcello Ceccaroni, Mario Malzoni, involved in international projects.
Amazing. And we're so grateful that you're working now in the endometriosis space as well. Could you give us an idea of what are some signs that endometriosis patients who suspect they may have thoracic endometriosis, what kind of signs and symptoms might they look out for?
Okay, yes. So the most common complication of thoracic endometriosis syndrome is to have pneumothorax, followed by hemothorax, hemoptysis, which is hemothorax is having an excess amount of blood inside the chest. Hemoptysis is coughing up blood, and pneumothorax is the collapsing of the lung. All these difficult words normally are associated when somebody searches on Google with symptoms that seems to be easily identifiable, which unfortunately is not the case. So the shortness of breath related to the pneumothorax in a healthy, fertile age woman is normally quite subtle. And therefore, one has to look out to quite subtle symptoms of more than shortness of breath. We can call it reduced exercise tolerance. Doing something that you normally do is harder to do it. Then moving on to pain, this is another very difficult to be diagnosed because the patients always know when they are in pain. The issue they encounter is that the doctor dismisses their pain because the common idea among many physicians is that is a period pain and it's normal to have it. But there are signs that you might have thoracic endometriosis, for example, having pain on the side of the neck or on the shoulder, that is not normal period pain. It normally is indicating the possibility that the phrenic nerve, which is the nerve that goes into the diaphragm, is irritated. And the involvement of the phrenic nerve is quite a telling sign that needs to be further investigated. The likelihood of you being believed by your family doctor or by the gynecologist is still low, unfortunately. And one patient has to advocate for a very long time. We know that in many countries, developed countries, the time to get a diagnosis of endometriosis spans from 7 to 10 years. But this is for endometriosis of the abdomen and pelvis. For thoracic or extrapleural endometriosis, we don't have data, but we can only assume that it's much longer, because oftentimes not even the doctor are aware of the existence of endometriosis outside of the pelvis. Then, last but not least, is going to have also other symptoms of presentation that needs to be cyclical, but not necessarily always cyclical. For example, a pain in the shoulder, the neck, or a shortness of breath that come every month, either in combination at the same time as ovulation or at the same time of periods, is another telling sign that should prompt further investigation. And again, I cannot stress enough how much one has to advocate for themselves. One thing to do is try to get a chest radiograph in a timely manner. Don't just go to the family doctor, because it's normally too slow. If you suspect that you have a sudden shortness of breath that is the third month in a row, that happens in combination with the period, try to go to the emergency department and get a chest radiograph. Once you have a diagnosis of even a small pneumothorax and a history of period pain, a history of cyclical shortness of breath, that the diagnosis should be done. And then the next step, I don't want to skip too many questions, is to find a specialist that understands what thoracic endometriosis is.
Yeah.
Sorry.
No, that's okay. Excellent overview. Is it common for somebody to have no pelvic pain symptoms, but present with the symptoms of thoracic endometriosis, or is that unlikely? If you're gonna have thoracic endometriosis symptoms, you're gonna have the pelvic pain as well.
Okay, so this is a very good question. I love it, because what I think that now we are in the infancy of thoracic endometriosis, and I am only diagnosing the tip of the iceberg or even less. So normally, all my thoracic endometriosis patients that I see in clinic are incredibly knowledgeable. They come with a big folder with the color-coded, chapters of their medical history, which is, on one side you could say is amazing, but on the other side, it worries me a lot, because it makes me think that I'm losing the other thousands and thousands of patients that don't have the tenacity, the family support, the financial means to pursue a diagnosis for such a long time. So, to answer your question, yeah, it is true that the patient I'm diagnosing nowadays are the ones that already have a diagnosis of stage 4 abdominal pelvic endometriosis, and then they get referred to me for suspected thoracic endometriosis. But I don't believe that only those are the patients that have thoracic endometriosis. There are thousands of other patients out there that don't get diagnosed nowadays. Just to tell you a little features that we spotted at surgery, we found patients with disease that skipped the diaphragm. So they have abdominal pelvic endometriosis. The diaphragm was completely clear, both from the abdomen side and then also when we went for a thoracoscopy on the thoracic side. But they had pleural and pulmonary endometriosis. So they were right all along for 15 years that they had thoracic endometriosis. But because that diaphragm looked pristine from the abdominal side, their symptoms were not taken seriously. So the disease can even skip the diaphragm altogether and being just on the lungs and the pleura. So I think we are missing out a huge proportion of the total amount of patients.
I agree. You don't have any data or statistics on how common thoracic endometriosis is, do you?
Well, so we know that endometriosis is believed to affect 1 woman in 10.
Right.
And so 10% of the population. And thoracic endometriosis is believed to be, according to very variable literature, between 1 and 5% of that 10%. So the 0.5%. So then again, you have to consider that the majority of patients will be asymptomatic. And we only diagnose those that have symptoms. When it comes instead to endometriosis, we have quite a few incidental diagnoses because of routine diagnostics that, for programs, for example, for program for women's health. So the endometriosis is still diagnosed incidentally through other means, but thoracic endometriosis is almost never diagnosed incidentally. The patient needs to have a pneumothorax or a hemothorax or, pain for many years before even be considered to be referred to a cardiothoracic surgeon.
I hear you.
Yeah.
Yeah. I don't know if this is an appropriate question, but can it be fatal?
Yes, unfortunately, I have been approached by a patient that she's on social media. She's quite an advocate, and she's the twin sister of a patient who died of thoracic endometriosis. She had surgery. Then she continued to have pneumothoraces, and although it remains still debated, and obviously we're talking a hot topic because I think there's still medical legal investigation en route. So I cannot really say my opinion fully, but definitely it played a role, or at least that's what we believe.
It's heartbreaking. Okay, I think you've already touched on this a little bit, but what does the diagnostic process look like for somebody who suspects thoracic endometriosis? I think you've talked a little bit about this already. I don't know if there's something maybe you could add there.
Yes. So whenever there is the suspicion of thoracic endometriosis syndrome, the first line of diagnostic could be as simple as a chest radiograph. Often people are afraid of the costs of diagnostics, but because the commonest presentation, three patients out of 4 with thoracic endometriosis will be a pneumothorax, a collapsed lung. It doesn't need to have advanced diagnostic. It can be as simple as a chest radiograph. But crucially, it needs to be done in timely fashion. It cannot be delayed. Even delaying by a few days, you might miss the diagnosis. The next step is to seek out MRI. MRI and not CT scans. CT scans are cheaper and often suggested by physicians because of cost reasons. But the MRI is the most sensitive investigation. And it needs to be done with a specific protocol for a T-sat fat saturated with endometriosis protocol, which if it is not done this way, it can be very difficult for the radiologist to identify any lesions. And oftentimes radiologists are afraid to report thoracic endometriosis or endometriosis in general because the lesions are below the current resolution of the MRI machines.
Oh, wow.
So the realistic situation is that I see something I'm suspicious, and I go down in the office of the radiologist, I put my finger on the screen, I say, well, you didn't report it, but what do you think it is, this? And they say to me, yeah, I know, I can see what you mean, but, if I put it in the reports, then, there's all the cascade of events that can take on from that point, because the patient will go to a surgeon and might get surgery for that. And then if there's nothing there, that they can sort of, point the finger at the radiologist. Because the radiologists on their side, they're not shy. It's only that the machine they're working nowadays, the resolution is not as good as thoracic endometriosis requests. The next step and the most sensitive modality is to do a thoracoscopy. For the time being, the naked eye is not really naked eye. It's actually used 4K cameras and with magnified by 16%. So, it's actually much better than the naked eye. But a thoracoscopy in a center where they have experience is the best way to have a diagnosis. And I cannot stress enough the experience of the surgeons performing. I have a case, which is actually not mine, but I was shown the picture of a surgeon in another center that was sort of wanted to show to the patient that she didn't have thoracic endometriosis. So took pictures of the diaphragm and gave it to the patient to show that she didn't have it. She brought them to show, and when he took the pictures of the thoracic endometriosis lesion. So the surgeons took the pictures of the thoracic endometriosis lesion to show the patient she didn't have it. And when she showed to somebody who knows what it looks like, they say, well, you already have your diagnosis. Those are your lesions.
Oh, wow.
So I cannot stress enough how important to go to somebody who understands how they look and what the appearance is expected to be.
Wow. Oh, yeah. Okay, so the process seems complicated. It seems complicated. So
do you want me to summarize it? Because I'm a chatterbox, I know.
No. It's great. I love the information. I'm sure everybody who will watch this will appreciate the information too. Was there something you were going to add there? Because I had a next thing I wanted to ask, but I think I might have cut you off there.
Yeah, I think it was just to remark the importance of having specialists.
Right. Okay, perfect. So, you laid out a couple of these steps. I think the reality for a lot of women who suspect that they may have thoracic endometriosis is this is a complicated series of steps. So my next question to you is, if somebody doesn't have the option, or maybe they don't have the option yet, maybe they can get some of these scans done, maybe they can find a provider who is willing to do an MRI, who's willing to do some of this other investigation, but they have to wait. Maybe they have to wait 6 months, 12 months, whatever it is. Do they have any other options? Does the thoracic endometriosis respond the same way as you would expect pelvic endometriosis to respond to hormonal suppressants or birth control or these types of options?
Okay, so when it comes to thoracic endometriosis, it's very difficult to comment on the efficacy of hormonal treatments because it's not really been studied. As far as I'm aware, the studies that we have now and suppressants of various modalities of hormonal treatments, they've been benchmarked against their efficacy in pelvic endometriosis. Okay. When it comes to extrapelvic, I'm very happy to stand corrected if anyone can come forward with studies that looked at the efficacy in thoracic endometriosis, but I'm not aware of anything solid evidence that I can quote when it comes to thoracic endo. What we know and we take from the pelvis is that hormonal treatment can freeze the disease or slow it down and can numb or lessen the symptoms, but they're not a cure. And actually, on occasion, disease can continue to grow and affect the diaphragm more. Or something that I see actually quite often, I see the patients when they decide to have a family, they stop their treatments, and they have plans to have a family. They are troubled by the sudden onset of severe thoracic endometriosis symptom, pneumothorax and various others, and pain. And if we think this is a quite tragic situation, because in the modern society we live, many women delay quite down the line to the edge of fertility and IVF possibility of access dates and age. And all of a sudden, when everything is set up, I have the house, I have the job, I have everything, I want to have children now. And then they stop the treatment and they start having disastrous symptoms of thoracic endometriosis. So this is something to consider when taking down the route of hormonal treatment. What I suggest to the patient is that maybe, you want to finish your degree for 1 year to have it, but then, don't defer it for 15 years. Yeah. Because it might be that then comes back and gives a lot of trouble when you finally want to have a fertility plan.
Complicates it a lot, for sure. Oh. Okay, excellent. So anecdotally, have you seen patients who are on, let's say, hormonal birth control or suppressants? Can you comment on that? Or do you not feel comfortable commenting on, do they notice a difference? Are the symptoms as aggressive? Are they better, worse?
Well, when it comes to hormonal treatments, I obviously through the years, I developed a lot of knowledge, but I am still a thoracic surgeon, a cardiothoracic surgeon. I think I should leave it to gynecologists.
That's fair.
Because you know how important it is in modern medicine not to overspill or to go over the boundaries of your own specialization.
Yeah, I hear you. That's totally fair. The other thing I was going to ask you, it escaped me. Hold on, will it come back? I was going to ask you any suspicions. This may be totally curveball, but any suspicions around, I don't know, theories, like why some people will present with thoracic endo and others don't? I know that that's a huge question and we don't even fully understand what causes endometriosis, but any suspicions or new research in this space as to why it would end up in the thoracic cavity as opposed to elsewhere in the body?
Well, there are a lot of theories. Some, are quite well known, and there are less traction nowadays, like retrograde theory. And there are some that actually say hematogenous, so it goes through the bloodstream or through the lymphatics, or even like embryological theory. So meaning that the cells are already there when we are fetuses and we are, growing up. But then under the pressure of changing hormonal statuses, they can actually start, developing. When it comes to the chest, I think it's fascinating to see how they have different color and appearances according to the stage, or at least that's what I have come to believe. Because when I see a patient with severe diaphragmatic endometriosis, on the right, where we know it normally arises first, it has more of a scar tissue appearance and hemosiderin-filled lesion, those dark purple lesions.
Oh, interesting.
And there are no more any of those patchy, like cauliflower-shaped brown or chocolate-colored lesions, which seems to be, or the sessile lesion, the pink one, which seems to be the more immature form of diaphragmatic endometriosis. And when I look at the left, diaphragm, which is normally where it arises second, and after the right for quite a while, I can see still that patchy appearance, which you have a combination of white lesions, they are the scarred one, and then purple ones, they are the hemosiderin, and then you have the cauliflower chocolate and the pink one that I think, in my idea, because of the commonest one I find are the earliest version of thoracic endometriosis.
Interesting. So like the ones in the earliest stage. Is that
Yes,
what you mean?
exactly.
Yeah.
Exactly,
Oh,
yes.
so kind of like the freshest almost in a sense, right?
Exactly. That's what I have come to believe. Although I don't have enough data, I'm building up an atlas. All my patients get like a lot of pictures, and I always tell them keep them, because you never know the paths of life where you're going to end up being. Maybe in 10 years you're in a different country, but you still can have your pictures with you, and you can show them to someone that will look after you in the future. And I'm building a lot of pictures, and I'm trying to keep them organized to have enough data to show that there is progression in the way that it seems intuitive that it's happening.
Amazing.
But yes, it's very early days to say that I know that this is true.
Sure.
I have a hunch.
Yeah, to be determined, maybe in a few years.
Yes.
Any new exciting research in the field of thoracic endometriosis that you're aware of? I guess you're participating in some, maybe.
Yes. So with Oxford University, I am collaborating with Tatiana Gibson and Christian Becker in a study in which they're using a new modality of imaging to try and identify thoracic endometriosis. And specifically, it latches onto the lesions. And that is the hope that it will allow patients to have a more precise and more sensitive diagnosis, because what we see nowadays, that MRI shows what we already know. I like our slogan. So basically, MRI shows the thoracic endometriosis that we have is so obvious clinically that we just use it to confirm it. We don't have any diagnostic tool nowadays that show us the disease that is subtle, that is hidden, that is, that's what you actually want from an investigation. Like, for example, we now have, mammograms can show us breast cancer 10 years before it actually develops, because we now have AI reconstruction of a mammogram. When it comes to thoracic endometriosis, we are the polar opposite. We only see on imaging things that are very obvious clinically, which is obviously not ideal. And I'm being British with not ideal.
Yeah, no, I hear you. Yeah, so it sounds like we just need a lot more research and needed advancements in this space. Obviously, I'm not a surgeon, I'm not a doctor, but I work with women exclusively who have endometriosis. And I want to say 5 years ago, it was rare that I would encounter somebody who has the symptoms that you described. And now it's becoming more and more frequent, that I'm being told, I have symptoms where I get shortness of breath. It's cyclical in nature, the collapsed lungs. So yeah, so much research is needed in this space for sure. Okay, I know.
And education.
Yeah.
I cannot stress enough, because, I see how now I have inspired a list of 2 of my trainees.
Oh, amazing.
Because the first time they saw it, they were like, because I know they have respect for me.
Yeah.
But because a large amount of the medical community does not really believe, or had never seen it, or he believes it's like one of those things that you see maybe once in a lifetime. And when they saw that, actually saw thoracic endometriosis in 60-70% of the cases we took for diagnostic laparoscopy, they were inspired, and I can see how something clicked in their mind. And then the same way, for example, this year for the first time, because I'm also the director of the European Fundamentals of Thoracic course, I've introduced thoracic endometriosis. And what I love about it is that it's going to be the fundamentals of thoracic surgery, not advanced, perfect, a course of advanced thoracic surgery. The fundamentals for trainees in the last year to pass the board exam, they will have to listen to me talking about thoracic endometriosis and show you them pictures.
That's amazing. That's amazing. I can't remember which show it is, but there one popular show, that streams on major like networks. There was a very powerful scene of a woman who was having the lung collapse repeatedly. So, at least we have that, and then we have you and your trainees, and you're starting this incredible, hopefully, revolution in the endometriosis space when it comes to thoracic endometriosis. So I know I'm grateful for you. I know that all the women in the endometriosis space are grateful for you. I know you're very busy, you're very in demand, so I guess we'll end here. I just want to thank you so much. Do you have any final tips or nuggets of information for anyone who's watching who may suspect that they have thoracic endo? I know you've given us lots of great information, but any final thoughts?
Believe your body.
Yeah.
Believe your body. You know that you will have a pain that is different. Believe when it feels different from what they tell you. Unfortunately, there are gaps in medicine and medical knowledge. Doctors are not intrinsically bad or arrogant. They are used as a profession to filter through a lot of false information, fake news, and Google and stuff. So they might sound dismissive or difficult, but that's nature of their profession. But you have to believe your body. You know that is different, and keep going. And I think we nowadays have the beauty of the social media and internet, which I actually really like. I really like the patient that challenge the status quo, and they try to seek out good quality information, because if one doesn't stop to the little dance on TikTok, you can actually find very good quality information on social media. So believe yourself and seek information.
I love it. I think that's a fantastic way to end off. Thank you so much for your time. I'm so grateful to you. Thank you so much for watching today's video. If you haven't already, please give this video a like, share it with a friend, and hit that subscribe button if you haven't already, and I will see you in the next video.